Good afternoon. Retinal tears. The risk factors for retinal tears include trauma, lattice degeneration, myopia, retinal detachment in the fellow eye, positive family history, and posterior vitreous detachment. The incidence of retinal tears in eyes with symptomatic PVDs has been estimated to be between 8 to 15%. A study by JOPHY et al. Has estimated that 1.8% of symptomatic PVDs progress to delayed retinal breaks, and if these delayed retinal breaks are left unattended, they may lead to subsequent retinal tears and retinal detachment. Retinal tears are most commonly located in the superior temporal quadrant and the least commonly in the infranasal quadrants. Posterior pole tears due to PVD and trauma are quite rare. Hence, we present a series of cases with posterior pole tears in different scenarios and discuss their management dilemmas. Case 1, 26-year-old gentleman presented with drop in left eye vision due to trauma to the left eye with the cricket ball. No systemic illnesses. Left eye BCVA 660, intraocular pressures of 30. The fundus examination showed vitreous hemorrhage, subhyaloid hemorrhage, posterior pole rupture, Berlin's and commotio retinae. Intraocular pressures were controlled with anti-glaucoma medication, and he was given a trial of intravenous methylprednisolone 1 gram per kg for 3 days in view of development of traumatic optic neuropathy. However, the vision was stable. These are multicolor images showing choroidal rupture on the first preoperative visit, second preoperative visit, and the third preoperative visit. OCT features also showing the same on the first and second preoperative visit, the preoperative visit. As you can see on the fundus picture, on the third preoperative visit, he had dense vitreous hemorrhage and the management was surgical. Intervention, he underwent vitrectomy, membrane peel, fluid air exchange, and endolaser. Post-op vision was, recovery was to 630 from 660. Retina was on follow-up examination with choroidal rupture. These are multicolor images on the first post-op visit, the second post-op visit. The OCT pictures on the first and second post-op visit. This is a fundus picture showing what the fundus looked like after surgery. Case 1 is a case of traumatic choroidal rupture with vitreous hemorrhage. Salient features to be borne in mind are guarded. Visual prognosis, subsequent scar contracture, ILM peeling and its importance to prevent progressive premacular membranes. PVD induction and ILM peeling can be challenging. Scar sparing is necessary to prevent ILM bleed. Case 2 deals with a 70-year-old gentleman presented with complaints of blurring of vision in the left eye. He had no systemic comorbidities. Right eye examination was unremarkable. Left eye BCVA 612 improving to 6.9. Pressures was normal. Lens pseudophakic. Fundus examination showed a branched retinal vein occlusion with an epiretinal membrane and a retinal tear temporal to the fovea, which can be evidenced on these multicolor imaging pictures, the first and second visit. The management plan was to give him a barrage laser therapy. As you can see, the scars can be seen. Also in multicolor imaging, the OCT picture after barrage laser. We managed this patient with barrage laser therapy and the vision was stable after the therapy. This is a picture showing, the fundus picture showing the sclerosed blood vessels and the barrage laser scars around the retinal tear. Case 2 is a case of break-in branch retinal vein occlusion. The salient features to remember are thin atrophic features of the retina, the unusual temporal location of the retinal tear, and that PVD-induced tears are not so uncommon. Case 3 deals with a 68-year-old diabetic gentleman who presented with complaints of photopsia in both eyes of 1 day duration. He had no systemic comorbidities. Right eye BCVA was 636 improving to 66. Intraocular pressures were normal. Lens was clear. Fundus examination showed laminar retinal defects nasal to the optic disc and vitreous opacities. Left eye features were within normal limits. As you can see the laminar retinal defects, breaks on multicolor imaging, and the OCT features showing retinal tears.
Where are the tears? I mean, show an OCT. You don't have anything full thickness anywhere.
So
Whatever is there is partial thickness.
There's a video.
Okay, continue. Play it again. Okay. I don't see any full thickness tears anywhere. Anyway, there are lamellar maybe tears.
Yes.
Holes. Okay.
So the management dilemma for this patient was, can we do?
You need to do nothing.
Observe. Management was to observe the patient. The vision was stable and regular follow-up. Call him at frequent intervals. So this case 3 is a case of lamellar inner retinal breaks. The salient features are what is the role of tangential traction, the role of posterior hyaloid phase and its management. Take-home message is the management of posterior pole tears needs to be considered based on the pathophysiology, cause and location of the tears. Decision-making process, although challenging, needs to be individualized with regard to the time and duration of the intervention. Posterior pole tears, though not uncommon, needs detailed evaluation, consideration, and timely intervention.